Hello everyone. Today we are going to see a topic about diarrhea in diabetics. You have to know that it's a very big problem and frequent in diabetic patients in comparison with normal person. And in fact we have two problems. We have another problems which is automedication, because diabetic patient, when he gets diarrhea, he doesn't go to his medical doctor, but he goes to pharmacy seller and gets his medication to decrease symptoms. Diarrhea is defined by WHO, World Health Organization, by passing watery stools loosely more than 3 times a day. And the medical doctor, when he faces this problem, he has to appreciate 5 things. First, describe the shape of stools and frequency. Second thing is to date their beginning using capital factors in diabetic life. Third thing is to appreciate difficulty and clinical severity, which means fever, weight loss, and bloody stools. And fourth thing is to decide exploration and kind of treatment. And at the end, take care of other disease like high blood pressure and diabetes control. So how to describe the shape of stools? You have to know that it exists many scales suggested, but the best used one is Bristol stool scale. You have 7 types stools, and the type 5, 6, 7 are the typical description of diarrhea. We see on this picture different shapes of stools. So according to the mechanism, we can classify diarrhea into osmotic diarrhea, frequent in diabetic patients because of glucose and treatment like acarbose, and secretory diarrhea, and the last one is motility diarrhea. Motility diarrhea is also frequent in diabetic patients because of autonomic neuropathy. The most important thing to do in diabetic diarrhea is to date the beginning. Dating in relation to several factors. First one is duration of diarrhea, and you have 14 days is the clue. The second one is to have time mark if the diarrhea is prolonged. For example, taking diabetes duration or changing any drug like metformin shape or acarbose, or adding some serotonin recapture inhibitors or statin, all can expose to diarrhea. The last, of course, dating the last species food, which can go back up to 4 days, and search about similar cases. At the end, we have to appreciate stools frequency, and you have to know that this appreciation is not only to make the definition, but also determine the character and the causes of diarrhea. For example, irritable bowel syndrome is characterized by diarrhea and constipations alternation. We can also classify diarrhea according to duration. So if duration is less than 14 days, we call it acute diarrhea. If it persists more than 14 days, it can be called persistent diarrhea, and if it still more than 4 weeks, we call it chronic diarrhea. Third important thing is to appreciate difficulty or clinical severity, which means if a patient belongs to extreme ages, pediatrics or elderly, he has more chance to be dehydrated. If it exists fever, so we have to take temperature. And if it exists dysentery, defined by bloody stools, and we have to appreciate also weight loss. So the most important thing after dating the beginning of diarrhea is to distinguish between watery diarrhea and dysentery. So dysentery is characterized by fever and abdominal pain and bloody stools and weight loss, of course. So on this picture we can see that an acute diarrhea can be infectious or non-infectious. Non-infectious, which means food intolerance or taking drugs like acarbose or metformin or statin or some antibiotics, and inflammatory bowel disease, which is chronic diarrhea, and you have also thyroid conditions, especially hyperthyroidism. So we have to check TSH if diarrhea persists after 4 weeks. So if we see the infectious causes, we can see watery diarrhea and dysentery. Dysentery, we have bacteria, and for watery the majority are viruses, but we can see some bacteria like Escherichia coli by using their toxins. The fourth point is to decide exploration. So we don't have to explore all diabetic patients who get diarrhea, but you have to choose some patients. So we can check blood tests like CRP, C-reactive protein, and ionogram to check potassium and sodium levels, especially if dehydration. And we can do coproparasitology if and only if there are signs of clinical severity like fever and weight loss and bloody stools. So not all patients have to do coproparasitology. And at the end we have abdominal ultrasound. We have to not to do it immediately, so we stay a while before do it to let inflammation disappear. Now we have also to decide about treatment. First of all, diabetic patient is exposed for dehydration because of two things. He lose water by urine and he lose water by diarrhea. So I have put 2 cups of water to increase drinking water for this kind of patient, because dehydration is very frequent and it can expose us for more severe problems like ketoacidosis. Give patient painkiller, especially if he has abdominal pain, and you have also slow down transit medicines like loperamide and diosmectide. For loperamide, 2 milligrams, the patient has to take 2 tablets, then he take 1 tablet before each diarrhea episode, and he hasn't to take more than 8 tablets per day. And the most important thing is that the patient has to stop taking loperamide when diarrhea disappear, because if he continue to take it, he risks to have constipation. Second point is which patient to put under antibiotics. You have to know that antibiotics are not systematically. We are going to use them only if the patient has dysentery, and we choose metronidazole in addition to one of 2 antibiotics, ciprofloxacin or Bactrim. The 5th important thing is to take care of other disease. So about diabetes, you have 2 possibilities. Hypoglycemia, it is logically because it can be explained by vomiting. And you have also hyperglycemia because of drug malabsorption. Same with blood pressure. You can have high blood pressure because of drug malabsorption, or low blood pressure because of vomiting and diarrhea. You have to know that diarrhea exposes to aggravation of chronic kidney disease because of dehydration. A special case is the pregnant diabetic woman. So you have to know that drinking water is an important element, because you have two lives, fetus life and human life. And the second important thing is you have to use different medicines. Only painkiller are contraindicated because it can relax the cervix and exposes to prematurity. And some antibiotics are also contraindicated, like Bactrim in the third trimester, because it exposes to jaundice. If diarrhea persists or still up than 4 weeks, you have to check thyroid condition to rule out hyperthyroidism and celiac disease by dosing EGA and some antibodies. And also we have to rule out inflammatory bowel disease. If all these diseases do not exist, we can say that it is an autonomic diabetic neuropathy characterized by bacterial overgrowth, and you have also bile acid malabsorption and pancreatic exocrine insufficiency, and some electrolytic imbalance like hypokalemia, and also altered gut hormone production, especially hyperglucagonemia, which exposes to chronic diarrhea. And we finish by this algorithm, which summarizes all causes of chronic diarrhea in diabetic patients. So first of all, we have to rule out laxative overtake. So you know that diabetic patients are also exposed to constipation because of dehydration. So diabetic patients lose water in urine because of osmotic urines. So the colon or large bowel will be dehydrated. That's why diabetic patients take more than normal person laxative. The second thing is to rule out all endocrine diarrhea causes like hyperthyroidism, Addison disease, and glucagon hypersecretion, and VIP hypersecretion. The third important thing is to measure stools volume and 72-hour fecal fat analysis. So for stool volumes, we have two situations. Less than 200 grams per day, it can be anal sphincter problems, and more than 200 grams per day, it can be infectious or parasitic process or irritable bowel syndrome. And for analysis of fecal fat, we have two situations also. If it is under than 6 grams per day, it can be idiopathic diabetic diarrhea. It means autonomic neuropathy. And if it is more than 6 grams per day, we can find malabsorption process like celiac disease and vitamin B12 deficiency. And we can find diabetic steatoria secondary to pancreatic insufficiency and bacterial overgrowth. So take these home messages. First of all, we have to date the beginning of diarrhea. The goal is to rule out diarrhea secondary to drugs intake like metformin, acarbose, statin, and some antibiotics. The second thing is to appreciate difficulty it helps us to decide which patients need exploration. For example, coproparasitology, we have seen that patients who have dysentery, bloody stools, and fever and weight loss need exploration with coproparasitology. And the third one is third message is decide which patient put under antibiotics. And the fourth is to treat others disease like hypertension and diabetes. And we have seen that both hyper or hypoglycemia can be seen, and high blood pressure or low blood pressure because of vomiting and drugs malabsorptions. And the final thing is to see if it is about chronic disease or it's just an acute diarrhea. If it is chronic disease, we have seen at the end the algorithm and how to manage chronic diarrhea in diabetic patient. And thank you for your listening.